This recording will go over disseminated intravascular coagulation, also known as DIC. DIC is an important concept for you to understand. With DIC, the patient is clotting and bleeding at the same time. The reason why is that the patient's body is forming clots inappropriately everywhere, and it's using up all the clotting factors in the blood. And then it has nothing left to stop bleeding when it needs to. So the big takeaway with DIC is that we have inappropriate clotting that uses up all of our clotting factors, and that results in inappropriate bleeding. DIC is never a disease that's just caused by itself. It is always caused by something else. So let's review the pathophysiology, or the what is going wrong with DIC. Something triggers the clotting cascade. Microclots form throughout the body. Platelets and clotting factors are used up, and then the patient starts to hemorrhage or bleed uncontrollably. Here are some causes of DIC. Sepsis is the #1 cause of DIC. The severe infection triggers the clotting cascade systematically. Trauma, especially crushing injuries, can trigger DIC. OB complications, and other causes such as cancer, especially leukemia, severe transfusion reactions, and shock. A memory trick for DIC is to remember D for delivery complications, I for infection and sepsis, and C for cancer and crushing injuries. The clinical manifestations result because of abnormal bleeding and clotting. So bleeding is going to produce the most obvious signs and symptoms, with oozing from the IV sites, bleeding gums, petechia, ecchymosis, hematuria, GI bleeding. We're going to monitor for bleeding. Skin findings include cool, mottled skin, cyanosis from poor perfusion. Clots can cause organ dysfunction, kidney failure, respiratory distress, brain issues leading to confusion and altered mental status. The microclots are going to obstruct blood flow to the vital organs, causing multi-system failure even when the patient bleeds externally. With DIC, and you're looking at the patient's labs, everything's going to be abnormal. Platelets are going to be low, PT-INR high, APTT high, fibrinogen low, D-dimer high. With DIC, just everything's a mess. You're going to see abnormal coagulation labs. Now, and just a reminder, with ITP and TTP, you see normal coagulation labs. Memory trick here for DIC is to think D for decreased platelets, I for increased clotting times, and C for chaotic labs. Treatment for DIC depends on the cause. If it's sepsis, we want to treat with antibiotics. If it's an OB issue, we want to deliver the baby. If it's trauma, we want to stabilize the patient. Without removing the trigger, DIC cannot be resolved. Secondly, we want to replace blood components. We can administer platelets, fresh frozen plasma. We can also administer cryoprecipitate to restore clotting capacity and control hemorrhage. Cryoprecipitate is a blood product that has higher concentrations of certain clotting factors, including fibrinogen and other clotting factors, more than fresh frozen plasma. So it has higher concentrations of clotting factors. Lastly, heparin is used sometimes, but not all the time. It can be used early in the clotting phase to interrupt the cascade. So it's possible to sort of interrupt that inappropriate clotting before the active bleeding occurs, that we would see heparin use. Nursing interventions for DIC focus on bleeding precautions, avoiding unnecessary sticks, applying prolonged pressure after procedures, and monitoring for bleeding. We want to monitor organ function, assess neural status, urinary output, and oxygen continuously, because multi-system failure can develop rapidly. We want to watch our IV lines, watch for oozing of blood, use the smallest gauge needle possible to minimize trauma. And we're going to frequently monitor our labs, watching for platelet trends and coagulation labs closely. We want to make sure we recognize rapid changes, because that signals the patient declining and a poor response to treatment. And here's a nice comparison chart between DIC, ITP, and TTP. Which one has abnormal coagulation labs? Hopefully you're thinking DIC. Which one is an autoimmune disorder that results in bleeding only? Hopefully you're thinking ITP. And then lastly, which one is a clotting disorder that can result in neural symptoms? Hopefully you're thinking TTP. So if you're looking at a patient with an abnormal bleeding, when they have some sort of bleeding issue going on, and their coagulation labs, PT, APTT, fibrinogen, D-dimer are all abnormal, that's the hallmark for DIC. The two other bleeding disorders, ITP and TTP, actually have normal coagulation labs. So remember, it's important to report any new or worsening bleeding, shortness of breath, or decreased urinary output. We got to make sure our patient stays safe to avoid injury and understand that this patient is very sick, so they're going to be cared for in the ICU setting. Clinical focuses recognizing signs, early signs, which include oozing from IV sites and abnormal labs. Remember, DIC is always secondary to another condition. So if your patient has one of those other conditions that put them at high risk, we're on high alert for this. Prioritize rapid intervention and multi-system monitoring. Remember, the patient's going to have abnormal clotting and then uncontrolled bleeding, which can lead to death if not treated. So we want to recognize this early. All right, one last review slide here. The core concept of DIC is that clotting and bleeding are occurring simultaneously. And this is always secondary to another condition such as sepsis or crushing injury. Things that we want to look for in labs is everything being abnormal, especially those coagulation labs. We're going to see decreased platelets, increased PT and INR, increased APTT, decreased fibrinogen, and increased D-dimer. A priority is to treat the underlying cause first. If it's sepsis, we're given antibiotics. OB-related, delivering the baby. If it's the result of a trauma, getting the patient stabilized. And a classic sign is oozing from the IV site. That's considered a hallmark clinical finding. So we're already assessing our IV sites frequently. It's something that you're going to be watching for patients who are at risk for DIC.